I'd like to welcome JuHae Lee, and she'll be presenting for us today. JuHae is a Master's of Science candidate in oral biology at the University of Manitoba, and she's under the supervision of Dr. Robert Schroet, and she just recently defended her thesis. She holds a Bachelor's of Science degree from the University of Waterloo, and she grew up on Grassy Narrows First Nations in Ontario. So welcome, JuHae, and thank you for presenting for us in this very busy time for you.
Okay. Hi, can everyone hear me? Hopefully everyone.
I can hear you.
Okay. Okay. Okay, wasn't sure. Okay. Thank you for that introduction, and thank you for having me here today to present. So today I will be talking about a project that I've been fortunate to be a part of the last 2 years, working with the Healthy Smile Happy Child project team to assess the oral health related quality of life of First Nations and Métis children in Manitoba. So here's like a brief outline of what I'll be talking about today in today's presentation. And to start off, I'll talk about some background. So one major public health related issue that Indigenous children in Canada face today is poor dental health, and early childhood caries, or ECC, is defined as a presence of tooth decay in primary children under 6 years or under 72 months of age. It is also known that many First Nations and Indigenous children are disproportionately affected by a more aggressive forms of ECC called severe early childhood caries, or SECC. Even though there are many reports of a reduction in caries in the general population of Canadian children, the problem and the increasing severity of dental caries among First Nation children is continuing to be an ongoing public health concern. Currently, many of the ECC-related studies indicates the common contributing risk factors associated with ECC, as well as the high-frequency measures of dental caries among First Nations and Indigenous children. Unfortunately, approaches that have demonstrated effectiveness in preventing ECC in lower-risk populations have not resulted in significant improvements for Indigenous children. There are currently no published evidence on the prevalence of ECC in Métis children, and also the oral health related quality of life, which I'll be referring to as OHRQoL, among First Nations and Métis young children was also unknown. Therefore, it was important to conduct further research in this area to promote young children's oral health and focus on enabling communities to identify strategies to develop resources and teaching tools to further prevent ECC. Once these have been established, any barriers that are preventing the First Nations and Indigenous children from having optimal oral health could be identified to help implement public health strategies by considering multiple approaches for prevention and oral disease management. This then leads on to the purpose of this research, which was to determine the burden of caries of young First Nations and Métis children and their associated OHRQoL. My research had 3 objectives. The first was to determine the oral health status of young First Nations and Métis children from participating communities, particularly the prevalence of ECC, SECC, and caries rates. Then the second objective was to determine the OHRQoL of young First Nations and Métis children. And thirdly, the third objective was to determine whether First Nations and Métis children's OHRQoL was associated with the prevalence of ECC, SECC, and caries rates. With those objectives, there were also 3 hypotheses. The first hypothesis was that ECC and SECC were both prevalent among young First Nations and Métis children from the participating communities. Second was that First Nations and Métis children had suboptimal OHRQoL. And thirdly, that the OHRQoL of First Nations and Métis children were associated with the prevalence of ECC, SECC, and increasing caries rates. Now moving on to methods, children were recruited as part of this larger study, which was the Scaling Up the HC initiative, which is a community-based participatory approach, and this was a cross-sectional approach. A total of 146 children under 72 months of age, along with their parents or primary caregivers, were recruited from each of the participating communities. Consent were obtained from the parents or primary caregivers of these participants, and caregivers completed an interviewer-led survey questionnaire, which included some information about the children's general health, dental history, oral hygiene and preventive practices, parent and caregiver knowledge of early childhood oral health, and demographic information about the family. Here is a map overview of the participating communities that were involved in this study. There were 4 total communities, which 3 of them were from rural areas. One of the 3 rural communities included First Nation community, and 2 of them includes the Métis communities, and the 4th one being here in Winnipeg. ECC and SCCC were differentiated and defined according to the American Academy of Pediatric Dentistry's definition. And for the dental assessment, DMFT, or cumulative score of total number of decay missing due to caries and filled primary teeth, and DMFS, which is the cumulative score of the total number of decay missing due to caries and filled primary tooth surfaces, were calculated for each child based upon the DMFT and DMFS indices. For the Early Childhood Oral Health Impact Scale, which I'll be referring to as the ECOAS, was used to assess the children's OHRQoL. And the ECOAS is a short validated tool used with parents and caregivers of children under 72 months of age, and it consists of 13 questions grouped into 2 sections, which is the child's impact section and the family impact section. The response options are shown here at the bottom right, with 0 being never and 4 being very often. And the maximum score per question is 4, and the maximum possible score for the entire questionnaire is 52. A total ECOAS score for each child was calculated by summing up these responses. The child's dental screening were combined with the parents' or caregivers' responses to the short survey, and this information was entered electronically into a REDCap database and was analyzed using NCSS and SPSS. Descriptive statistics by varied analyses such as chi-square, t-test analysis, and analysis of variance, and linear and multiple regression were performed. Main outcome variables included ECC, SCCC, DMFT, DMFS, and ECOAS scores, and covariates in the models included child sex, age, indigenous status, the community of residence, parental education level, insurance status, dental visit history, and SCCC status. These covariates that were considered for the regression models for ECOAS scores were deemed to be exploratory. And lastly, a p-value of less than or equal to 0.05 was considered statistically significant. As I mentioned earlier, a total of 146 children were recruited in this study from October 2018 to December 2019, and the mean age was around 40.1 months in age, which is around 3 years of age, and 49% were males. Now, if we look at the table here on the right of the parental characteristics, we see that the majority of parents and caregivers were mothers at 86.3% and completed high school education or beyond. Now, this table here presents the prevalence of ECC and SCCC by place of residence and communities. And when the prevalence of ECC were compared between those living in urban and rural areas, there was no difference in the prevalence of ECC. However, there was a significant difference in the prevalence of SCCC between children living in rural areas compared to those from urban centers, as you can see it highlighted in this section of the table. Now, when communities were also individually compared with each other, the prevalence of ECC was not found to be statistically different from one another. But however, the prevalence of SCCC was found to be significantly different between communities, specifically the urban Winnipeg area differing from the other 3 rural communities. The associations between ECC and SCCC prevalence between First Nations and Métis children were also assessed, and overall, So you can see in this left part of the figure that 65.4% of First Nations children in Manitoba had ECC compared to the 45.2% among Métis children, which showed a statistically significant difference between the two Indigenous groups. However, there was no statistically significant difference in the prevalence of SEC, as you can see in this right side of the figure, between First Nations and Métis children. Now, when looking at the dental data, the mean DMFT score was around 4.9, ranging from 0 to 20, and the mean DMFS score was 14.5, which ranges from 0 to 80. And when dental caries indices were compared between urban and rural dwelling children, both the mean DMFT and DMFS scores were found to be significantly higher for those in rural areas compared to those living in urban areas. The analysis was then further assessed by comparing the mean DMFT and DMFS scores between each individual communities. And ANOVA showed that there were significant difference in the mean DMFT and DMFS scores between these communities. And Tukey's analysis also revealed that urban community, so Winnipeg, significantly differ from the other three rural communities, showing lower mean DMFT and DMFS scores in comparison to the rural areas. With ECOA scores, 2 participants were omitted to either missing information or hesitating to answer the survey questionnaire. So we had ECOA's data for 144 children as opposed to 146. And to highlight some points from the survey questionnaires, taking into account of all the total who responded as occasionally, often, or very often, when we look at here at the child impact section, 13.9% responded that their children experienced mouth pain, and 11.1% had difficulty pronouncing words, and additionally 9% had difficulty eating occasionally, often, or very often. And here at the bottom in the family impact section, taking account of the total who responded as occasionally, often, and very often again, 21.5% of parents reported feeling guilty, and 14.6% of parents were upset with their child's dental condition. So for the total baseline ECOA score, it was around 4.44. Which ranges from 0 to 30, while the mean CIS and FIS scores were 2.65 and 1.78. Furthermore, chi-square analysis revealed that the OHRQoL was associated with the prevalence of ECC and with the prevalence of SCCC. And the results here showed that the scores were significantly higher among children with ECC than caries-free children, as indicated between the yes and the no of each section in this table. Likewise, children with SCCC had higher mean CIS, FIS, and the total mean ECOA scores in comparison to those who did not have SCCC. With the multiple regression, a total of 126 children were included in these analyses when observations were made with these following predictor variables indicated on the left side of the table. And when systematic basic predictors were analyzed with one another, only one predictor variable, which was SCCC, was associated with the total mean ECOA scores. However, stepwise regression analysis revealed that 2 of these covariates were significantly and independently associated with total mean ECOA scores, which was age and SCCC. OHRQoL association with caries rates were also performed through linear regression, which revealed that there was a positive association between the total mean ECOA scores and the DMFT scores. And similarly, there was a positive relationship between the total mean ECOA scores and the mean DMFS scores as well. So to our knowledge, this is the first study to assess the oral health status of young Métis children in Canada, and the data analysis suggests that the majority of First Nations and Métis children have ECC and SECC in Manitoba. There was a significant difference in both the prevalence of SECC and caries rates between children living in rural communities compared to those from urban areas. And being consistent with prior studies, this result was not surprising as the location of residence can significantly impact the convenience and likelihood of a family visiting a dental clinic for regular checkup. Due to the likeliness of better access to care in urban areas, this can also indicate that children in urban settings might have better oral health than their counterparts from rural communities. This research is also one of the few studies in Canada to assess the OHRQoL in young First Nations and Métis oral health. And this matters as oral health is not only about dental statuses such as caries status and caries scores, but also the impact caries has on childhood well-being, quality of life, and families. Children from the urban community have significantly lower total mean ECOAS scores compared to the rural communities, indicating that there was a suboptimal OHRQoL, especially in rural areas. The higher mean ECOAS scores translates to children having poor OHRQoL, and this result again was not surprising since participants in urban regions can easily access to dental services compared to those in rural areas. So with that, our baseline total mean ECOAS score, as I mentioned earlier, was 4.44. And as you can see here in this figure, this paper that was published by one of our lab team made an international comparison of the baseline total ECOAS scores in which the children who participated in our study had similar OHRQoL to other children of different populations. It was noted that a Canadian ECOAS study from Quebec who used a validated French version of ECOAS recorded that their mean total ECOAS for parents rating their child's oral health as relatively poor was 10.8, where for this particular study, where this figure came from, their total mean ECOAS score for pre-treatment under GA was 6.27. And if we compare the ECOAS value, what we had for kids with caries or with ECC or SECC, it was around 6.2, which was quite similar in comparison as well. But overall, these variation in these scores suggest that different factors such as culture and population are needed to be taken into account and can affect scoring. And the parents and caregivers' lack of recognition or even being in denial of how their child's dental problem are affecting their OHRQoL may also exist. An interesting finding was that despite 56.8% of parents or caregivers rating their child's health as very good, only 17.5% rated that their child's dental health as very good. A common misperception that many people tend to have is that oral health is separate from general health, and parents and caregivers may not consider oral health as a component of overall health, as it was evident in their responses to the ratings of their child's general health and dental health question. In this study, it was also interesting that despite 92.1% of the participants having dental insurance, only 55.5% of the children had visited a dentist. Again, access to regular and preventive dental care is a challenge for many Indigenous peoples, particularly those residing in rural and remote regions of Canada. In this study, there was some limitations in strength. Even though the sample size was small, the majority of children from each rural communities were screened. And other limitations include recall and response bias, where parents and caregivers may have had some difficulties recalling answers to the retrospective questions that were asked in the survey questionnaires about their child. And response bias is also possible since parents and caregivers' ratings about their child's health and the answers to the ECOAS questionnaires could differ from the child's own health ratings. Another limitation is the fact that this is a cross-sectional study, therefore the data results are bound by the timeline of the study and inferences about causations cannot be made. This study has several strengths. This was the first time that ECC prevalence of Métis children and OHRQoL of First Nations and Métis children that were examined in Canada using ECOAS. And as opposed to using secondary data source, data were collected in person from each of the participating communities and the data were considered a reliable source for looking specifically at First Nations and Métis population groups in Manitoba. Lastly, scientifically valid research was achieved using the validated scale that has internal consistency and reliability while respecting First Nations processes and goals of self-determination in this study. So as long as the same method of data collection is used at baseline and follow-up with in terms of self-completed or interviewer-led, reliable results can be obtained. In conclusion, this is the first Canadian study exploring the OHRQoL of Indigenous children in addition to their oral health status. ECC and SCCC were prevalent as 59.6% and 55.5% of the participated children were affected. Oral health disparities such as ECC and reduced OHRQoL exist among many First Nations and Métis children in Manitoba. And children who had caries and resided in rural areas had poor OHRQoL compared to those who were caries-free or resided in urban regions. These findings will help inform community-based oral health promotion and ECC prevention activities, and it also establishes the baseline findings that will be compared with the assessments at the end of the study project to determine the overall effectiveness of the scaling up the HSHC initiative. Here are my list of references and acknowledgement to my funders and the study team that I was involved. Thank you for listening.